So I'm sort of dividing it into two sections. I'm going to focus on the neurotransmitters on Friday, and I'm going to focus, really, this is more about the anatomy and what the parts are, and a little bit about what the autonomic nervous system is about, both the sympathetic and parasympathetic divisions. So that's kind of the focal point for today. So we're using this PowerPoint, really, but a lot of it's going to be skippable, as you will see. There's a lot of language about the ganglia and where they're located and all their names, and frankly, I don't care. I mean, it's not something I would ask you about. So if we're doing this today, as you'll see what we cover and how we cover it. On Friday, it will be focal point about the neurotransmitters and specifically what they do, and particularly about the names of the receptors that are so important and they lead into pharmacology. And on Monday, I'm hoping that, to me, that's going to be effectively a review session. It is surely optional. Okay, if you're so, I mean, for some students who are not taking the final because they're happy with their grade as it is now, that's fine. And I mean, you're more than welcome to come to the review if you wish. Anybody's welcome to come to the review. I'm going to be here anyway on Monday. So, however, I mean, because I know a lot of you will be, maybe having an exam on Tuesday and are busy with that. I'll certainly record it if it's relevant to record it and pass it along to you for any of the classes. So that's basically where we begin today. When I put on the board, the sympathetic typically involves nerves from T1 to L2. Okay. Well, you're going to see it's called thoracolumbar because it's thoracic nerve, lumbar nerves, and the parasympathetic, I have bad. Parasympathetic, called the cranial sacral division, and involves specifically nerves 3, 7, 9, and 10. And I'll get into all those. And sacral really is S2 and S2. And the principal mediator of most of it is the 10th cranial nerve, the vagus. I'll have a little bit to say about those because it's really something I suspect that you probably just learned the names of the cranial nerves, but not a whole lot more about the cranial nerves than what was there. So as we begin, we'll start here and just a quick review. Effectively, it's innervating stuff that we don't have any control over. So smooth muscles, all those hollow tubes, whether they should be expanded or contracted, whether they should be closed or open, any way you want to describe it. The activity of the heart, all things we don't give a second thought to as long as we're healthy. The glands in our bodies, again, as long as everything, we don't, it's something, that's why we call it autonomic or automatic, and a lot of people refer to it as. And it's all about homeostasis and very, very much about pushing the blood to where it's supposed to be at the different times. So basically, putting the blood to the area where it's needed the most. Okay? And it's all in subconscious control. By definition, that's involuntary. Here's the construct. Again, sympathetic, technically, it's a motor system, part of the peripheral nervous system, and the two divisions are sympathetic and parasympathetic. I'll say it more than once more time. They work beautifully in concert together. If you want to understand it, just go back and you're going to see a number of graphics as we get, maybe not today, but probably toward the end of the chapter or the end of this PowerPoint sequence that describe the sympathetic nervous system and particularly what's called fight or flight. If you understand that, that's the closest thing to pure sympathetic activity. So whenever you're scared, you have to run away, you're exercising at peak activity, you're doing a sporting event, all of those things. Think of what happens. Your eyes are wide open. Your respiratory passageways, and I forgot to bring it with me. Oh. Okay. Hey, about. Sorry. Can you wait a little bit?
Yeah, of course. I have a break at 11, so it works out.
You're fine. Okay, you have a break at 11?
Yes.
Meet me then. Meet me here, and we'll go over to my office.
Okay, perfect.
I'm so sorry.
No, don't be sorry. It's okay.
Okay. I'm sorry. It's okay. I had no idea where my cell phone was it was buried in the car. That was Monday. It was one of those days. I fell and so already do not tell my eldest, who thankfully is in London, because he's going to have me in the nursing home in a minute. He figures I'm losing it. My dad walking around without clothes on, just let me know. We'll get him in the nursing home fast. It's true. Don't look at me like that. If you get anything that says .mil from a military thing, I want information about this man from an Adam M. Stein. You'll know it's my son, the eldest. He's very annoying. Moving on. So the closest thing to fight or flight, okay, is pure sympathetic. Think what happens. Your eyes are wide open. Your secretions are all dried up. You know, you're not putting out saliva. You're not putting out anything. Your mouth is very, very dry. When something like that happens, that allows your respiratory passageways to be wide open. Your respirations are going at a very, very rapid rate. Your heart is growing at a very, very rapid rate. The blood flow is no longer going, other than just to keep it working, barely, to your digestive system or your genitourinary system. All of your blood is being redistributed to your skeletal muscles and to the heart, so it can pump out maximally. That's what fight or flight is. If you remember what that is and all the nuances, that's pure sympathetic. The opposite, parasympathetic. Most of the time, sitting here like you are in what we call the parasympathetic mode, known as rest and digest. Basically, your blood flow is the vast majority of your blood, other than the usual places, is going to your digestive and to your genitourinary system, particularly digestive and urinary, because that's what I think about overnight. When you get up in the morning, most of us, what do we have to do? We have to go to the bathroom. That's because those systems have been busy overnight when you're at rest. That's that's their opportunity, because you're not occupied doing every other things. The same reason in the middle of a sporting event or an activity, it's unlikely, and certainly if you were running away from somebody, it's unlikely you can't say, potty break. Maybe they won't catch me. It just doesn't work that way. I know it's silly, but silly examples are the kinds of things that a lot of people find it easy to remember, I think. Do you know what that doofus said in class today? That's basically the way to remember it. No smiling, you guys in the back row. Then my wife saying, "Are you still saying those same stupid stories in class?" I said, "Yes, dear." So we know they have different fibers and effectors and pathways. The neurotransmitters are going to be very, very significant as we look at the construct that's there. And we know it doesn't involve skeletal muscles. And this is what I had on the board before. I'll show it to you a little bit better as we see it coming up with this pre and post ganglionic stuff that are there. So I'm scrolling through these importantly to understand these types of things. Okay. So the autonomic nervous system nerves, you're going to see this is an example. When you're busy exercising, you're going for a major workout in the gym or outside, active muscles require more oxygen and glucose to the autonomic nervous system, speeds up the heart rate and opens airways, for instance. It's just trying to give you some context. This is where we got to start today. Importance. Here is a typical, when they say somatic, this is the typical nerve going to a muscle. We spend an inordinately large amount of time. It's a myelinated nerve. It's very fast. And it releases acetylcholine, and it goes to the muscle, and by definition, it's stimulatory. And this is where we start to talk a lot about it has to do with the receptor, whether the effect is to excite something or to inhibit something. You'll see that. The sympathetic nervous system is very interesting, okay? It has, and this is what we talked about before, all of these systems, sympathetic and parasympathetic, we use the fancy terms because where the nerve synapse, and there's a bunch of them, and it's outside of the central nervous system, it's not within the brain or the spinal cord, we call those ganglia. All of the pre-ganglionic fibers, all of the nerves emanating from the start of the sympathetic and parasympathetic system release acetylcholine. So the preganglionic fibers, as we'll describe them, here, the sympathetic nervous system, here, this unusual one where it's going into the adrenal medulla, I'll get back to that in a second. Here, in the parasympathetic, they all release acetylcholine. And it's always excitatory. The oddballs come after that. So you're going to see most of the sympathetic nerves, what we call the postganglionic nerve, and the fact that it's not myelinated or lightly myelinated is not important. They release a norepinephrine, with one exception that we'll get to before we conclude today. And as you can see, the response is either positive or negative, stimulatory or inhibitory, depending on the neurotransmitter and the receptors. This applies to both of these. All of the parasympathetic postganglionic fibers release acetylcholine. So acetylcholine is the big player we already knew about going to skeletal muscle, and now we can see in the autonomic nervous system, it's also the big player, with the exception of postganglionic fibers in the sympathetic nervous system. And yet we still have another oddball. Most authors think this is really a ganglion that for some reason is sitting inside of a gland. This is called the adrenal gland. And we name norepinephrine, its old term was noradrenaline. It's named for the adrenal gland. When you get to endocrine, you're going to study it again. Adrenal means adjacent to or next to, in this case, on top of the renal structure, which is your kidney. These two little mounds of tissue sit comparatively small on top of the kidney. The exterior portion is called the adrenal cortex. That's a true endocrine gland. Its secretions kind of ooze out and are surrounded by a giant nest of blood vessels and sucked up very quickly. We call them corticosteroids because they come from the adrenal cortex, and they're steroids because they're all made from cholesterol, which has a steroidal kind of chemical nucleus. And you'll look at that probably a little bit when you start to see it when you look at endocrine. And they have very, very famous names that you're going to learn about. One's called aldosterone, one is called cortisol, and the other ones, when you start hearing about anabolic steroids, a lot of them come from there as well. Very interesting. I'm giving you a little intro to it in endocrine. The interior of any structure. Remember, the exterior is always the cortex. The interior is the medulla, just like bone. Medullary bone and cortical bone. That's why these terms keep showing themselves to you as you move on educationally with anatomy and physiology. And hopefully you'll have somebody who's as clever as I am in explaining them to you, and I'm sure you will next term. The interior of this is called the adrenal medulla. We think it's a misplaced ganglia, and it's really a good way to look at it. This gives off both epinephrine and norepinephrine, or as we know them, adrenaline and noradrenaline. It's the reason we call an EpiPen an EpiPen, because the adrenaline plays a really important role, and that's what we're going to look at next time as to why that's so important. Okay? Think of what happens in fight or flight. Again, whatever example you want to use, the idiot is going to cut you off and, oh my God, I just almost got into an accident. The reason you have that prolonged heart rate, panting, respirations are very busy, you feel like, oh my God, I'm never going to calm down. And maybe it lasts, depending on how severe the scare was, so to speak, it might last for a few minutes, a few seconds, or it might last longer than that. That is the prolonged reaction in your bloodstream of epinephrine and norepinephrine going into your bloodstream. They work similarly, but not exactly identically. And I do not know whether that is in this chapter. Maybe a little bit of it is in this chapter. If not, you'll see it down the road. because it releases these chemicals. If this is the ganglion, it kind of is the postganglionic nerves are actually inside of it, and they release it directly into the bloodstream. And that's that prolonged effect when you have fight or flight. Okay? That's the jumping off point for the rest of today. A lot of these slides that I'm going to really zoom through, we don't have to worry about. I'm not going to ask you the names of the specific ganglia, whether it's pterygopalatine or whether it's in the splanchnic nerves in the gut. Don't care. My advanced anatomy class, then we care. Medical school, then they care. Depending at a graduate level, then they care. The parasympathetic division is the maintenance division. It's what you're doing now, conserving energy. I'm expending the energy, although minimally talking to you. So theoretically, if they measured my heart rate, it would surely be greater than yours. Believe me, it's greater than yours. I mean, none of you have a granddaughter who's 24, I would dare say. My oldest grandchild is 24 today. God, my old. Nobody here with a 24-year-old grandchild other than me? Don't smile. You could marry somebody that could be a step-grandchild. You're looking at me like, what the hell is it doing? And so when we're sympathetic is we're during activity. And so as soon as you leave this room and walk wherever you're going, your activity level is going to increase. And gradually your sympathetic nervous system is going to start to engage, comparatively speaking. So if you have to race back to the dorm because you forgot something or race back to your car, then your sympathetic division is going to be increased dramatically. So, and they use a wonderful word, and it's not all areas are equally innervated. That is a mistake, as PowerPoints often do. It's not all visceral. You can make a case that that's true, but I won't do that. Dual innervation, most would be a much better term, of the structures in your body have dual innervation. And that's this wonderful, what they call dynamic antagonism. It's a beautiful way of expressing it. It's pushing and pulling. They're tugging against each other. So when one says be active, the other one is holding it back a little bit. Okay, that's the beauty. That's what homeostasis is. Oh, we better elevate our blood pressure. Something's coming up. Oh, bring it back down. You're done. It only took you a minute to deal with that problem. Now bring it down. Oh, I need a rush of sugar. Okay, now you got it. Now let's utilize it. Stop. That's kind of what happens in this system. And it's all about homeostasis. So your body energy from the parasympathetic is as low as possible, even while carrying out maintenance activities. So overnight, you're doing all of these things. Your digestion, your kidney is basically diuresing, it's forming urine. And typically you get up in the morning, you have an urgency to go. And sometimes you have to go to the bathroom, have a bowel movement. That's just standard stuff. Nothing surprising about this. That's why they call it the rest and digest system. So blood pressure, heart rate, respiratory rates are relatively low. Gastrointestinal activity is high. And this is the big one. Pupils are constricted and the lenses are accommodated for close vision. What does that mean? See, if you had the time to have the full picture on sympathetic, parasympathetic division, if you're studying cranial nerves, you would have learned that 3, 7, 9, and 10 are not a ton of cranial nerves, just those. 3 is the interesting one to talk about now. Number 10, we're going to cover at length as we go on. That's the vagus nerve. The vast majority of parasympathetic fibers go into all of your organs that come from the vagus nerve. It's the only nerve that feeds the head and the neck. It's its name from vagabond. It's a wandering nerve. It wanders all over the place, as you'll see. 7 and 9 basically innervate salivary glands, which you'll learn about in digestion. The oddball is 3. So you basically just learn the names of the nerve. Which is number 3? Remember the name? Starts with 3 O's. Factory, optic, and oculomotor. And it's the one that you typically learn about. It's when you're doing an exam, and particularly a neurological exam. It's like this. Up, down, right? That's that one. You're following your finger. Those extraocular muscles. LR6, SO43. Shows that. See? That's so hard. But we're not done with 3. 3 has parasympathetic activity. So when you do a physical assessment, I'm already teaching you assessment for here. Okay, you have a pen line. You all do. We're doing assessments. You're sitting in your lab coat. And you hold it up this way and bring it from the back to the front. What does the eye do? There's a pupil. Comes, gets in touch with light, it constricts. And it's not just one side, it's both sides. They're equal. We look for symmetry, and we look for asymmetry. If somebody had maybe a concussion, they're typically one-sided. You look to see, well, that one constricted, but the other one's kind of doing it rapidly or too slowly. And so you bring it in from the other side. They should both respond similarly, whether the light comes from here or here. And that's under the control of the parasympathetic nerve as part of the oculomotor nerve. At the same time, the rest of that test is we shut off the light and say, focus on the tip of this pen light, even though the light's not on. And you bring it closer to that. And what do your eyes do? We call it accommodation. They begin, basically your eyes focus toward it, they move toward the midline, and the pupils constrict. That's called accommodation. And we use an acronym on a chart called PEARL. Pupils are equally reactive to light and accommodation. All about the third cranial nerve, the parasympathetic portion. The other portion, the voluntary motor portion, is following my finger. That type of thing. See? You already got that down for physical assessment. You'll impress it. Miss Dr. Betsy's her first name. If she's doing the assessment, and hopefully she is, don't tell her I gave you a heads up. We actually used to do that stuff. It's been a long time for me, I know. But I don't think the physical assessment is part of what's called the neurological survey. That's what that cranial nerve thing is about. It all plays a role. Now you see them in football games, they're in that blue tent. You can't see it, but in the old days on the sideline, they would do that. How many fingers do I have? Follow my finger. Try to move your jaw against pressure. All that types of stuff. Start to swallow. That's what you do. Blink, nod, blink, wink, that type of stuff. You're testing cranial nerves. Sticking out your tongue, you're testing 12th cranial. Go back and look at it. That's really important stuff. So hopefully they'll start with that, or at least address that at the start of AP2. As I said, I'll reach out to the folks who are teaching it and let them know this is where we left off in the lecture portion. So all of those things, pupils are constricted and the lens are accommodated. This is fight or flight during activity. It doesn't have to be an emergency, but it is. It could be just embarrassed over something or excited about something. Just watch me during the Steelers game when they actually do something right. As opposed to me throwing things, I do get excited about that when they do something wrong. Okay? Exercise, excitement, emergency, increased heart rate, dry mouth. Think of what you have to have if you're going to have to be running away. You can't have a bunch of secretions. And intentionally in surgery, what we do is a preoperative medication. We give them, and I'm sure they still do today, probably a different medicine. We give them something to dry up their secretions so we can intubate them because it gets in the way. This is something if somebody goes in, if you're nursing, you go into a master's program called CRNA and become a nurse anesthetist. That's when you're writing those orders. Okay. Some of the pre-op medication, generally in the old days, the physicians wrote the orders. Now the protocol, at least when I had patients scheduled for operations, they said I gave my pre-op orders were specific to what I wanted them to do for what I was going to do. But the anesthesia, I said, do you need anesthesia pre-op orders? No, nurse anesthetist. Gotcha. Okay, vigorous physical activity. The blood goes to the skeletal muscles in the heart. Where does it come from? gastrointestinal, genitourinary. It goes down to a trace, as you will see when you start to study how the blood is distributed. The bronchioles dilated. And notice bronchioles. This is the part where the EpiPen comes in. When you get to respiratory, your trachea leads into two main bronchi that are quite large. They don't collapse. And then it branches about 23 different times. Bronchioles are to the point where you can't see them with the naked eye. What happens, the muscle around them, when someone has asthmatic attack or anaphylactic shock, does this. Air can't get in. So when someone's in anaphylactic shock or having asthma, you can't, using a trach, that's for a blockage here, not there. Okay? So that's where the EpiPen comes in, because that will bronchodilate, and we'll get to why it does. And we'll actually name the particular receptors, which are really important. You're going to hear about them on Friday. They're called beta 2s. And that's important because you're going to see all of these with regard to medicines. Even though the names have changed, the usage is very similar. Shunts blood for the skeletal muscles in the heart, dilates the bronchioles, and you need an energy supply. This is where it comes from your liver. So, I mean, all of this, and a lot of this has to do with exercise science and things like that. It's the reason we're able to, our energy supply, your liver starts to induce your body to break up fats. That's why when you're exercising after a certain amount of time, you go into a fat burn. First it's cardiac and your immune system, and then you go into fat burn. So if you study that, and that's why my wife was insisting for these 5 weeks that we have off that I back to the gym and start working out. She wants me to get in shape. And as you know what I've said to her, round is the shape. She doesn't acknowledge that. Three main differences between sympathetic and parasympathetic. Parasympathetic, craniosacral, brain, and spinal cord. The spinal cord portion innervates the reproductive structures and some of the urinary tract. That's why we call it genitourinary. The role where we see the greatest example of these two working together is in sexual excitation and climax. We get to that next time. So you'll see that. The parasympathetic is involved in sexual excitation, whether it's male or female. In climax or ejaculation, whatever they are, be it male or female, that's the sympathetic nervous system. They are not motor-based functions. Okay, there's a whole myriad of different things, and when you start to talk about, when you start looking at the reproductive system and reprophysiology, you look at that more closely as to how those systems work. But this is sort of the short course on it. The sympathetic fibers are called thoracolumbar in the thoracic and lumbar regions. This is the length thing, relatively speaking. The parasympathetic have long, think of the vagus nerve. It goes a long way from where it starts to go to your different organs. We call that long preganglionic fibers. The sympathetic, as you will see, that change starts very, very close to the spinal cord. So a short preganglionic and long postganglionic. Somehow figure a way to memorize them. Paras, long then short. Sympas, short then long. However you figure out a way, make up an acronym, make up a saying. I'm sure there'll be at least one test question about that. Please. This is the illustration. It's not 100% accurate. It sort of supports the idea of what they're missing with that all organs things. Here's the paras. The eye we talked about, the salivary glands. Everything else is vagus when you're talking about the thoracic and most of the abdominal cavity. Heart, lung, stomach, pancreas, liver. And we get down to the sacral area, now we have bladder and genitalia. Sympathetic. Notice it has all the same things. Eyes, salivary glands, lungs, blah, 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 genitalia, bladder, all that good stuff. But wait, there's more. Skin. When you are in fight or flight, when you are working out, you have to cool. You're generating a tremendous amount of heat. That part of your skin is principally sweat glands. Because when we perspire, perspiration evaporates and we cool. So that's one. The two that are missing from here, and you see them neither here on parasympathetic or sympathetic, are blood vessels and the kidney. Your kidney is all about blood flow. Your kidney is effectively a high pressure filter that filters your blood continuously. If your blood pressure falls below a certain level, your kidney will shut down. Your kidney is a unique organ. It's really just a nest of blood vessels and tubes that filter your blood and cleanse it. Okay? It's high pressure, so when the pressure drops, the filtration system doesn't work. If your kidney has a blockage, it does the same thing. It stops working. The kidney shuts down. If there's damage to it, if there's an infection, if there's a blockage, it shuts down. Particularly, it shuts down when blood pressure falls below a certain level. We have a word for that. When your blood pressure falls so low that your kidneys stop working. That name is shock. You will hear about circulatory shock. This one is called hypovolemic shock. Because when you don't have enough volume, maybe somebody's bleeding out externally or internally. They go into, or they've lost a lot of fluids. When you go into that, that's a ticket for ICU. I had that ticket back in 2006. I had a 3-night stand because of a massive infection in an ICU. Don't like it. You hear that story if we were together in micro, because at that time I was 55 years old, and they called my 87-year-old mom first night and told her I was close. That's how sick I was. But lucky you, I'm here nearly 20 years later, giving you all a hard time, forcing you to put up with these bad anecdotes and terribly unfunny jokes. So what they're not showing you here are blood vessels, because that's what your blood pressure is all about. The smooth muscle around those blood vessels is what controls blood flow, and that is your blood pressure. And you don't see kidney here because effectively that's all about it. So the sympathetic nerves, as you will learn, are pivotal, and you'll learn chapter and verse about this, particularly when you start talking about blood vessel and cardiovascular physiology. That comes in AP2. Really important stuff. And they go into all the organs and where they're located, and I don't care about most of this stuff. We'll talk about the neurotransmitters next time when we meet. So here's just to finalize these divisions. Craniosacral, the fibers originate from the brain or the sacral region. They're long and then short. Same illustration here, for instance, oculomotor nerve. By convention, they use Roman numerals. Control the smooth muscle of the eyes, cause pupils to constrict, lenses to bulge for focusing. And so what happens, they're related together. When your pupils constrict, your lenses become more rounded, and it focuses your vision to where it's supposed to be when you start looking at the eye anatomy and physiology. For distant vision, when I'm looking outside here, maybe to see, I saw an ambulance or something like that, or a police car, your eyes dilate so you get a big picture. Your lens is flat because, again, it directs your vision towards it. It's why we're wearing glasses, whether you're nearsighted or farsighted. So you hear a lot about that. I would anticipate in both lecture and lab and AP2. Okay. The other thing, a little clinical nugget, this is how we determine if someone has an overdose of whether or not we should use Narcan. When someone has a narcotic overdose, their pupils become pinpoint. When someone has a speed, ecstasy, amphetamines, cocaine overdose, their pupils are dilated. Most of the time, if you can't determine for sure, or if there's something, or they're combative or whatever, and they're usually not combative generally with an overdose of narcotics, they're bad. You're in big trouble. As it is, what we end up doing is we give them the Narcan anyway. It wouldn't even hurt in the other direction, is my understanding. You'll learn more about that. But that's one of those quick things. We didn't have the luxury of having those things. Narcan was available, but it wasn't something that was relatively easily found unless you were in an emergency room. It wasn't something that you could have at home or at school. But that's another one of those little clinical nuggets, and you don't even have to tell them that I gave that to you. One of the ways we determine whether it's a pinpoint, whether it's a speed overdose, cocaine speed, or excitatory in nature. So facial nerve, these are all glands, and these are the secretions. We don't want those secretions to be there. Normally we have a lot of those. In surgery, we want to block those. We'll learn about that next time. Vagus nerve, 90%, so to speak, geographically. All these different plexes and ganglia and stuff. You don't have to know any of those names. Don't care. I want you to know that the vagus is basically everywhere. And it's all those internal organs that we talked about, branches to not just the lungs and the heart and the bronchi, but branches to the stomach, liver, gallbladder, pancreas, small intestine, even part of the large intestine. When you get to the sacral area, now you have the remainder of the large intestine, the bladder, the ureters, and particularly reproductive structure. And it shows you the illustration of where they're going to. You can blow this up and take a better look at it. Again, note the absence of blood vessels, note the absence of the kidney, note the absence of the skin. Sympathetic has a lot more complexity if you want to really think about it, because it's in some structures, and this is the important, remember exceptions, which are not dual innervated. The sweat glands to cool you during fight or flight. When you get excited like that, just think of it. We get excited about something with goose pimples, goosebumps, whatever you want to call them. Your hair stands on end. Those erector pili, muscles you learned about in skin. Remember those? Sure you do. You say erector pili? I know you can. I'm doing my Mr. Rogers thing. I never told you the Mr. Rogers story, did I? Oh, remind me on Friday. You all want to hear it, don't you? You guys in the back want to hear it. Friday. It involves that son, my other son. The erector pili of the hair follicle and the blood vessels, and so too the kidney. Again, we call it thoracolumbar, typically T1 through L2. And those lateral horns I mentioned in passing, that we only see in those areas, those are gray matter. They're specifically going to sympathetic nerves. Not a big deal for you to know that either. Same illustration. I'm not worried about rami communicantes or sympathetic trunks. You're going to see where they're located. See, this is where the sympathetic nerves are located. In the old days, before we had more sophisticated ways of bypass grafting, and we had different technologies where we could do angioplasties and balloon angioplasties. What they would do before, in the hopes that you didn't have to amputate, is because they knew the sympathetic nerves were controlling blood vessels, we took out the sympathetic chain. Which never made a lot of sense to me, but that was a procedure. I actually scrubbed in on a couple of those, where I'm holding the retractor and the chest surgeon's pulling these out. It was a chest surgeon. And that was the hopes that you could, when they weren't there, the blood vessels were wide open and the person would get circulation to his legs and we wouldn't have to amputate. We never saw one that worked. I just told you all you had to know, but that was what they call standard of care, a term that you're going to get used to. That was the procedure you were supposed to do in that thing. Thankfully, I think they learned from a lot of the mistakes that were there. And so I'm not getting into all these ganglia or collateral synapses, et cetera, not important, or rami communicantes, et cetera, any of those things that are there. So, I mean, to me, there's just, it's too elaborate, too extensive for what we need to know. Frankly, if you know fight or flight, that big of it, fight or flight, and being pure sympathetic and all the things that it affects, if you just remember that one, the opposite is parasympathetic. Because a lot of the questions are like, in fight or flight, your heart does what? It accelerates. In fight or flight, your blood pressure does what? It elevates. In fight or flight, your blood flow goes to where? Skeletal muscles in your heart. So those would be the kinds of answers. And really that's a lot of the questions you're going to see on the final that are pertinent to this chapter. Certainly there'll be some that are a little more, some of those questions will be a little more specific, but if you know those, you're good to go. You're already good to go. So all of those types of things that we had talked about already are there. And again, you don't have to go through which plexus it is and what it does and blah, blah, or splanchnic nerves and all that type of stuff. And celiac or superior and they used to call this the old solar plexus. Somebody would get a blow in their gut right below their xiphoid process, right at the junction of the diaphragm. I mean, somebody would, like that. You could hardly, that was being hit the solar plexus. There's a lot of things. It was what boxers had almost such strong muscular bellies so that would prevent them from being hurt doing that. I don't know what it is today because we see less boxing and more mixed martial arts, and that ultimate fighting and that type of stuff. It's different. I'm getting there. Yeah, all this stuff. Don't have to worry. None of this stuff. Some preganglionic fibers go to the adrenal medulla without synapsing, so it really isn't a ganglia. We think that portion of the interior of the adrenal gland is and I'm all in with this because most of the authors I read agree, is a misplaced sympathetic ganglia, and there it releases. They have this misspelled. It should be also called noradrenaline and adrenaline, not noradrenaline and norepinephrine. So in the old days, again, adrenaline, and that's why we named it for the gland that it was located, adrenal gland. So we called it adrenaline. We thought that was the only thing it produced, but it's not true. There's other things when you get to endocrine you'll learn about. And so norepinephrine, epinephrine, and they work somewhat subtly differently in the body into the systems they affect. And if it's in this chapter, I'll comment about it. That are there. Here it is in there. This is this ganglion, so to speak. This exterior portion, something that's really pure endocrine, you learn about it there. And here, the blood flow and the blood vessels into it immediately suck this stuff up, so to speak. So we get a lot of information. Most of the information comes from the area of the hypothalamus, which is where the blood-brain barrier is weakest, so to speak. And so it can assess sugar levels, salt levels, different chemical levels, different kinds of hormone levels in the bloodstream, and make the appropriate adjustments that are there. A lot of times we have other, like for instance, they'll talk about the gut a little bit. In the stomach, in the small intestine, you don't have, even though it's under autonomic control by the vagus nerve, your gastrointestinal tract works fine without it. You did not know that. What happens is it has their pressure sensors, stretch receptors, chemical receptors, and as the food goes to different areas in your esophagus, your stomach, small, and then your large intestine, what it does is it triggers these receptors by stretching it, by having certain chemicals that are associated with it. Much of that stuff you typically learn about when you learn about AP and digestive physiology in AP2. And we call it the gut brain. It works on its own. And just to underscore the point, again, this is why I'm uniquely here talking to you. I have had half of my stomach removed not once, but twice. In 1993 and 2000. They had to, at both times, section the vagus nerve. In other words, they took out a piece of the vagus nerve going to my stomach because of the ulcers that I had. So, yet, it still works, obviously. To understand, it's not, sometimes we think of things that are essential. If they did to the heart, you would die. But your gastrointestinal tract has its own nervous system that, think of this as more of an override, the sympathetic and the parasympathetic. Okay, and so without going crazy about that, or the reflex arcs, and the effectors are smooth muscle, cardiac muscle, and gland, not skeletal muscle. That's the uniqueness of that system. And so there's a lot. This is the enteric nervous system. All of that is something that is not something that we effectively do not have to control, even though it can be controlled by sympathetic and parasympathetic that are there. And then we're going to get into this, and this is where we're going to start next time with this naming convention. The major neurotransmitters of the autonomic nervous system are acetylcholine and norepinephrine. So you're going to learn about fibers that release acetylcholine, we call cholinergic. Fibers that release norepinephrine, because it used to be called noradrenaline, are adrenergic. And we're going to learn about the receptors for them. And that's really the important part vis-a-vis pharmacology. That'll be next time, and we will stop here. Thank you. Have fun. Hopefully see you Friday for this.